Hello and welcome to this Ask Me Anything live stream webinar with Dr. Christopher Lunsford. My name is Samantha Mellinger and I am the Director of Partnerships and Marketing for the Health Professional Student Association, which publishes the Student Doctor Network forums. Our mission is really simple. We help students from underserved communities increase their chances of admission to health professional school. And we do this by offering donor-supported guidance, advising, and assistance to students, regardless of their background or financial means. And so we invite you to check out all of the many resources that we have available at studentdoctor.net. Let's see here, just a few housekeeping items before we get started tonight. First, this live stream is being recorded, so you'll be able to go back, rewatch it, or even forward it to a friend who maybe wasn't able to attend tonight. Also, to submit a question, all you have to do is enter it into the comments section of YouTube or Facebook, wherever you're watching, and we'll pull it on the screen for Dr. Lunsford to answer. And now let's get going with a little background on Dr. Lunsford. He is a physical medicine and rehabilitation doctor specializing in pediatric rehabilitation medicine. He is the co-director for the Cerebral Palsy and Related Conditions Clinic at Duke Health. He's a former philosophy major and pre-med at Wake Forest and went on to medical school at UNC Chapel Hill. He completed his residency at the University of Virginia and his fellowship at the University of Pittsburgh Medical Center. So now I will turn it over to Dr. Lunsford. Why don't you start by sharing a little bit more about yourself, as well as what exactly a PM&R physician is for those who might not be as familiar.
Yeah, that's great. And again, I want to thank you all for the chance to be here today and to do this AMA. And it's really great to be a steward of my field, both physical medicine and rehab as the parent discipline and specialty, and then my subspecialty of pediatric physical medicine and rehab. So a real quick primer for those of you who may not know. So PM&R is a smaller field. It's not often even a required medical school elective. It is a non-surgical neuromuscular field based around function and quality of life. So if you think about what therapies can do for patients, but they don't have the medical background, and what orthopedics and neurology can do for patients, but they don't have the functional background. And so rehab doctors really fill in that gap between those two or three, depending on how you look at it, areas. And again, full medical school training, but with the right amount of ortho and neurology to make into a functional plan for people. And so then in the pediatric side, again, luckily, most kids don't need a rehab doctor, but some kids are born with physical disabilities. Some kids go on to develop them because of trauma or injury. And these disabilities, again, require sometimes a non-surgical neuromuscular specialist. And in my role as co-director of the Cerebral Palsy Clinic, I end up helping kids with muscle tone abnormalities, spasticity, hypertonia, helping them get to the therapy plans that they need, the equipment that they need, sometimes treatments and medications and injectable treatments that are for focal spasticity. And so the end result for me is that I get to help kids with their function, but their quality of life, and help them play better and help them have more fun. And that ends up being really rewarding for me. And again, I have been on the East Coast and from North Carolina. So coming back in 2019 to Duke is a little bit of a homecoming for me. And PM&R is really strong regionally across the U.S. So the Northeast and the Midwest have a lot of really strong programs, but the South, we don't have a ton of really strong programs. So it's kind of a little bit more likely you might not have heard it if you're looking at programs in the South and might not go to a program that has a strong rehab department. So why don't I leave it at that, unless the only other thing I was going to say in my intro is that part of my calling is also to be a disability advocate. And that what I mean by that is that disability has been under-recognized in society as actually an important part of human diversity. and that having disability in of itself is not the negative that people might think it is. And the role of medicine is not to erase disability from the face of the earth, because that's sort of naive to think that disability would ever not be part of the human condition. We all age, for example, and a lot of elderly people have disability. And if you think of it as the enemy, then you're really promoting something called ableism. And so that's something that is a real near and dear to my heart topic, and it's really interwoven into my practice as well. And I myself am hearing impaired, but that's not necessarily my charge here. My charge is to help us recognize that in a world that we don't recognize that curbs are the disabling feature of some areas and spaces for those that use wheelchairs, for example. So I can't wait to hear some of the questions that we have and maybe go from there.
Awesome. Let's see here. We will start with, when did you first decide to become a physician and why?
Yeah, I saw that this was one of the questions that a lot of the AMAs start with. And I have to say, it's a hard question for me to pin down a time on. As you mentioned in my intro, I went to Wake Forest and I was a philosophy major. And I chose that on purpose because Wake Forest happened to have a really, really great department in philosophy that had a variety of really interesting professors to work with. And I was looking at one of those charts that said, you know, what majors do people go into med school with? And way down in the bottom was philosophy. But instead of saying, oh, that's not a good one to pick, I said, oh, you can actually still get into med school if you do philosophy. And so for me, it was, I didn't want to go straight into the pre-med courses, knowing that I could circle back around to it if I still wanted to and fit it in my curriculum. And I was thinking about law school at the time. So then as I finished through the philosophy and had enough of the pre-med requisitions, what I decided was kind of the turning point was, what do I want to do with my time and talent? That mixture of how do you fit and how do you find yourself fitting into the world? And I'm an introvert with pretty good extroverted skills. I like to problem solve, and I like to see the benefit of what I'm doing in real time. And so medicine was just a much better fit for that than law school or being a philosophy professor. So that was, to me, it really fit into, well, you know, this pathway seems like it can help me show my skills and give to my in a service that is meaningful for me.
Absolutely. So we've got our first question from the audience. What does a typical workday look like for you?
So that's a great question as well. And if I can, I'll explain a typical workday for me, but also for rehab in general, because that's one of the other great parts of physical medicine and rehab, or PM&R. It's also called physiatry or physiatry, depending on if you're East Coast or West Coast, respectively. And again, we don't necessarily call ourselves physiatry or physiatry all the time, because that lends to even more confusion between us and psychiatry and us and physical therapy. But again, for rehab medicine, there are so many things that you can specialize in. You can be a traumatic brain injury doctor, a spinal cord injury doctor, a pain medicine doctor, a sports medicine doctor. So as you can imagine, all those different subspecialties within the rehab umbrella would look like a different workday. Some of those are predominantly inpatient specialties, where you need to be with patients recovering from brain injury, working right alongside the neurologist and other people that when it's in the active phase of that recovery. Others are predominantly outpatient, like myself, where I'm having clinics more often than not. And then there's a hybrid of a lot of procedures. There are some people that are electrodiagnostic specialists. So they spend their whole day doing nerve and muscle studies to help diagnose rare conditions of axonal diffuse injuries and or carpal tunnel or radiculopathy. So you can really help, even when you choose rehab, you still have so many options ahead of you. And so for me, again, I have my clinics. I have sometimes out of clinics for research time, administrative time. I'm building a lot at Duke and trying to help peds rehab grow where we're at as well.
Great. So what are the most challenging and also the most rewarding aspects of your specialty?
So the challenging aspect of the specialty for me is so I'm very attention deficit, and so my mind goes in a lot of different directions at once, and so then I have to circle back into, okay, what are we going to do now? And one of the reasons I love working with kids is that I get to think about their future and the 6 month, the 1 month, the 6 month, 1 year, the 5 year, the 10-year plan all at once, but I can't give all of that to the family that day. And so it can be challenging to have all of this and exciting things that I want to see for the child and help them think about and educate. And then sometimes challenging that I see this potential and know that they're going to go back to the 3.5-hour drive to the rural area where they're from, where they don't have some of the resources to carry out the plan that I have in my head. And I just wish I could snap a finger and give them all of those urban or suburban resources in a rural area, and I can't. And so I have to really struggle with, well, what can I do? What is the best that I can do? And not necessarily take it as a personal failure that just because I could imagine asking them to move to the city to get all this other stuff, that wouldn't necessarily work for every family. And most families, it doesn't work for them. And the rewarding is again, knowing that families hear and see what I tell them, and they immediately get, this is a different type of doctor. They immediately say, this is what I was hoping for, rather than someone who is taking my chief's complaint and giving me one plan for that chief's complaint today. We really look at the delivery and the sharing of information in a way that doesn't fit into this model of medicine that's been built on efficiency and billing. And so that's the rewarding aspect, is just getting that feedback from families.
All right. Have you always been open about your own disability? And if not, where did you begin or start that process?
Yeah. That's a great question from Pepper. And Pepper and I think, have been in several other talks before around this subject. And so I'm so glad to see her here tonight. And essentially, I have not always been open about my disability, but only because I have not necessarily felt there was a big value in highlighting it. And so what I mean by that is I was kind of indoctrinated, if you want to say, to the ableism of our culture, meaning that as a white male, the last thing I wanted someone to think was I was highlighting my disability to get attention. So I was very much saying, nope, I don't need any help. I'm going to do exactly what everyone else is doing. I have enough white, I realized my white privilege way before I realized how my disability and talking about it could actually help others with disability. Because we can learn from each other, and we can take some of the stigma away from it. And so when did I start was actually when I started as an attending. I had finished med school, finished residency, finished fellowship, and never really understood that identifying as disabled was a positive thing for my life. Honestly, I didn't think of it as a negative either. I just didn't think of it. I didn't think of it as one way or another. But after joining the Disability Advocacy and Action Coalition at the University of Virginia, which was an undergraduate faculty and student group, I started to learn a little bit more about disability studies. And that's when it clicked with me that I'm missing out on being able to help my patients in this way by talking about this and explaining my own experience, but also understanding what's wrong with how we treat patients, and we treat those with disability, and oftentimes we make them feel broken when that was never the intention, but that is what they take away from our medical care that we try to offer sometimes.
right, our next question. Are there state or federal programs that help physiatrists pay back medical school loans given that their salaries are lower?
Well, that's a complicated question, and it's complicated on a number of levels. One is that you have state and federal programs that I know about are really only the loan forgiveness ones based around working on, I think, tax, nonprofit, and a lot of academic institutions count for that. As it stands with the salaries part, lower than what would be my question, because I think the salaries of rehab physicians by and large are above the mean for all physicians, but certainly above the mean for physicians of primary care background. And for example, my salary as a pediatric rehab doctor, I studied for 4 years in my residency and 2 for my fellowship. And when you compare my salary to pediatricians, I'm a bit over. In a lot of other pediatric specialties, I'm a bit over. So I still have a lot of trouble paying back the school loans, but there's not any grant funding programs that I am aware of, and I'd love to know if other people are. I am getting some reverberation. Is that just me, do you think, or are you hearing it as well? I'm hearing my voice twice.
I am hearing a little bit maybe with the mic, potentially, but I'm not hearing a second at all.
Okay. I'll back away from the mic a little bit.
You're good. All right. So you've touched on this a little bit, but what are some more positive and also negative aspects of your field?
Yeah, it's hard to, in my mind, identify a negative in the sense that I think there's so much self-selection that luckily occurs. If I was thinking about the negative, I would think that the only negative I can imagine is that we have not been very good at explaining how we're helpful in the business of medicine, if that makes sense. So the business of medicine really in this idea of where is value, utility, and the improvement in outcomes. We have not done a good job of showing that if you have low back pain, you should be seeing a rehab doctor first, not an orthopedic doctor, not an orthopedic PA, not a neurologist. You should see a rehab doctor first. And yet, if you Google back pain doctor, the first 20 hits will be ortho types of things, and then after that will be lawyers, and rehab popping up on there. And so I think the negative of why haven't we been able to get the good word of rehab out there is partly because we think in different ways about what outcomes are positive. And at least in my field, for the pediatric side, it's really hard to show that a peds rehab patient, someone with cerebral palsy who might have some difficulty walking, the things that I do in education and training with the family and the parents when they're 2, 3, 4, and then with the child who becomes a young adult themselves at 13, 14, 15, and how they process their own condition, those two, I still look at, well, this is someone that might walk in the community really, really well until their 40s, 50s. But without some of those rehab aspects and the kind of breakdown of their gait and not really keeping up with what's important, without that, sometimes they may stop walking in their 20s. And that's 10, 20 years of mobility lost. And right now, there's no outcome measure that anyone tracks for a patient in a hospital system that has a strong rehab department that kept that person walking for 20 more years and one that didn't. And yet we all know if you are not mobile, your risk of having metabolic syndrome, prediabetes, heart disease skyrockets. And we've missed out on that. So to me, it's a negative that we have all this knowledge, all these things that are clearly helpful, but it doesn't pop up in the U.S. News and World Report that what we've done. And so again, the positive goes with that is that it's such a strong field that is focused on trying to find what's important to the patient and helping them achieve that.
So in general, has being a physician met your expectations? Why or why not?
Expectations. That I would say they certainly have not met my expectations, but that's because I have a very interesting set of expectations. Um, I just so want the world to be a better place than it is sometimes. And so for me, it causes a lot of angst in me that there's things that I want that I cannot achieve easily. And I feel like I have to compromise in some ways that I'm not happy about. But I'm also spending energy to do the work that I think that I need to do to get to those good places. And that's one of the reasons that I came to Duke. Duke is traditionally not strong in the rehab medicine sciences and the rehab for specifically rehab medicine. Now, we have extremely strong programs in physical therapy. We have a doctorate in physical therapy. We're getting a doctorate in occupational therapy. We have a wonderful PA program. We have so many things that fit around the rehab, but we don't have a rehab department. And so I came here knowing that I've got to build, but the expectation is that if I can get a chance to build, I'm bringing rehab to a bunch of children that wouldn't otherwise have easy access in the Duke system. There's other great places in this area. And so for my expectations, it was, it should have been easier than this. But it's not. It's hard work. And I think sometimes when you find your calling, you find yourself doing things that are important to you, and sometimes it becomes obvious, well, that didn't just happen. That's not there because someone didn't come and build it. And so that's where sometimes for myself, I kind of have to just say, oh, no, that's what I'm here for. That's why I'm here to build it.
Absolutely. So Jane has a follow-up question. What are the recent and most exciting breakthroughs in the field?
Yeah, that's a great question as well. And, recent in terms of it's still experimental, but very close to what I think will be rolling out for use in my mind are in like the prosthetics field and having neuroprostheses. So instead of having a prosthetic that interfaces with only the limb and the skin, really integrating the computer processing of the joint that you're replacing through the prosthetic or the limb that you're replacing with the remaining active nervous system in order to help the patient be even more functional. I mean, that to me is just so exciting. It's not something that I do on a daily basis myself. More along my lines in the recent world is the use of augmentative reality and virtual reality to augment therapy training programs. And so, but that's useful in rehab patients, but also useful in training soldiers in the military or training someone who eventually, I think, people will be doing that sort of thing to train for surgery before doing the actual surgery. And so, but rehab has a strong role in that because, again, we can translate some of the needed functional things for patients along with what is acceptable within their medical regimen and their program. And recent, but now on the flip side of coming hopefully down the pipe, and for me, it's the world of robotics and assistive and adaptive technology. We're seeing so many things get accessible at a very quick rate, and the entry barrier for things to be accessible is getting lower and lower. And I think that that's going to really help us be ready to kind of go into the new digital future. And so with both how we interact with the internet, but then robotics for people, helping people have exoskeletons that can finally be affordable, helping people have smart power wheelchairs as opposed to just power wheelchairs, will be a future that I'm really excited to hopefully see in the second half of my career.
So could you speak to how the roles of a PM&R physician and physical therapist differ?
That's a great question. And I will go one further to say, speak to the role of a full rehab team. So when I say rehab medicine, I'm speaking about my role. When I say rehabilitation, I'm speaking about a highly interdisciplinary process. And so rehabilitation can include a rehab physician. On the rehab team could also be the neurologist or the orthopedic for the overall rehab plan. But then you also have the nursing specialist, a nursing care coordinator that's part of the rehab plan. You have the physical therapist, you have the occupational therapist, the speech language therapist. You might also have a specific developmental, vision, music, child life therapist. I could go on depending on what you're building. And the relationship between what the rehab doctor brings to the team and what each individual therapy group can bring is really meant to be one of being on the same level, not a hierarchy. And again, being on the same level of both doctor, therapist, and family and patient. And so the reason that it's helpful to have a team like that is that if a condition is sufficiently complicated enough, you really do need everyone spending their time excelling at what they're good at. And the therapist, when they get down into the nitty gritty, they need to focus on, for a physical therapist, growth motor, core control; for the occupational therapist, it's activities of daily living and fine motor control. But the rehab doctor can help by zooming out and saying, okay, there's only 24 hours in the day, or only 3 hours that this patient can work before they're too tired to do anything else today. So it can be thought of as almost like an orchestra, which again does have a hierarchy of the conductor and the different parts. But the conductor is needed because each of the different parts of the orchestra cannot hear itself very well. And they can hear what they do really well, but they need the conductor to say when they're playing loud or low or what part of the song. And if it's a different song, they need to play a different role. And so for me, PTOT speech is my brass, percussions, and woodwinds. And we, again, as long as we ignore the hierarchy part of it and we're all together, we have a back and forth of let's try this based on where the patient is and what they need.
That's a really good analogy.
Yeah.
So what experiences would you recommend a medical student interested in pediatric rehab seek out?
Oh, there are so many types. And so on the example of the patients that I had mentored, students that I had mentored and helping them find experiences, you name it, and we could probably relate it back to what you might be looking for as a medical student. And whether it was trying to find a volunteership, where for me, I actually got the idea to become a pediatric rehab doctor by volunteering at a camp for kids with disabilities. And I was a summer camp counselor at the Victory Junction Game Camp in Randleman, North Carolina, the middle of nowhere, the very first summer they ever existed. And I remember thinking, if I'm going to go to med school, how can I work with these kids? And how can I see them on the good days and the bad days, not just the bad days? Because a lot of times you only see these kids, if you're in the hospital, on their bad days. And it took a while to figure out, but rehab was it. So that's like a volunteership, but then you also can try to find, if your medical school doesn't have a department, you can try to see if you could do an away elective. Almost all of the departments welcome students that are prospectively going to try to match into rehab to come and experience their program. And again, there's even more creative ways to get out there if someone's interested.
So taking it back to medical school, how and why did you choose the medical school that you attended?
Yeah, so it's kind of not an exciting decision process for me. I applied regionally to all pretty much East Coast schools. I did have a choice between a few of them, but then went with UNC Chapel Hill because it was the best for the location and the best for kind of the fit of the variety of things I wanted to see, with also being very, very reasonably priced. And so If I had it to do over again, would I look for different things? The only thing I would look for differently would be ways to that the medical school empowers its student to be a part of exciting change. And I think that different schools are getting better and better at that. That it's not just 4 years of only learning, but that the school learns from the students as well. And I don't know of any schools that are doing that better than others, but that's the kind of question that I would be asking in my interviews.
So what surprised you the most about your medical studies?
I would say what surprised me the most about my medical studies is that the amount of times that I felt like a fly on the wall was many more than I thought it would have been. And, again, at first you're like, well, what am I getting from this? And one of, I think, of the real mature things about as you go through your clinical rotation, just to realize your fly on the wall times are actually some of your most informative times if you know what to look for. And so it's a passive experience that you have to make active and have to think about what you're seeing, what are you learning from this experience. And again, by being mentally active, you think of more things to go and learn later. And, for me, there was a lot about how communication was happening when I was a fly on the wall that I was like, wow, well, I can tell that this doctor doesn't understand that what this patient was asking. Why is that? And like, I would go back and I would think about it and think, what was it that was missing in that? Because in the moment, as the lowly medical student, I didn't say much, and it wasn't. There weren't bad situations. It was just, how can I learn from that? And so that I'd say that's probably surprising to me, is that those passive times were some of the most thought-provoking.
So how do PM&R doctors interact with the school system? And which providers do you get referrals?
So the school system, I think they're meaning, I'm not sure if this is with the medical school system or with the public school system for my role as a peds rehab doctor. So I would say adult rehab doctors don't have to interact with the public school system very much. They might have a lot of interaction with occupational medicine where someone gets hurt on the job, but not as much with schools and accommodations for that. For me, my interaction is very much trying to figure out, is the school system promoting the child, public at the agencies? Okay. Is the school system promoting the child's rehab plan and working in concert with the rehab plan? And especially since a lot of states run their physical therapy and occupational therapy and a lot of other supports through the school, we have to try to maximize that. But those programs are there to maximize the child's learning. So I still can't ask the school therapist to help teach the child how to learn a new dance move or adaptive sports move that they really want to learn. Sometimes we have to still work with other therapists outside of school for that. And the ADA, the IEPs that students have, those will take my recommendation. I don't get to dictate what they do, but I make recommendations, and by and large, they are things that help improve the conversations that families have with their school system. And then I'm getting referrals by and large from a variety of people, but neurologists and orthopedic doctors, I think, are the first two that kind of go back and forth with sending me patients that they see first. And sometimes also the patients that are in the NICU follow-up clinics, because patients that were particularly born early are at a little bit higher statistical risk of having cerebral palsy. So I'm sometimes brought in to say, we think this is a gray area case. We want to make sure that this child doesn't get left behind in their developmental skills.
So why did you choose pediatrics over adult?
Well, a variety of reasons, but the most important one is that I myself am just a big kid, and I rather be in the company of kids for trying to help them succeed, and being around their infectious, contagious joy of what they experience, no matter what a kid could be going through. I am never, it never ceases to amaze me how kids sometimes fight and try and do their best. And so with adults, it's not that adults can't be motivating and inspiring for me, but it was sometimes hard when you would see a patient for the third or fourth time and know that no steps have been taken on any part of the rehab plan that you outlined for them. And there's always good excuses, there are, but that's a little bit less often in the peds world, because not only is the kid almost so many times trying their hardest, and so motivated, but the parents are motivated to get the kids to the places where they need to be successful. And the other part to me is that I'm not very easily satisfied with situations where I feel like I'm doing a lot of bread and butter. So that's not necessarily meant to be a bad thing. It's good to have things that you can do efficiently and not out of the park, because it's kind of very easy for you, and not letting the patients know that this is a run of the mill case. But for me, run of the mill kinds of things, then I start to mentally kind of slide off into daydreaming. And every single case I have is often there's some aspect of it that I need to tailor immediately to that situation. And that could be because the child has slightly different involvement of areas for arms and legs that are have hypertonia, or that could be that the education level of the parents and what they need to be, how I need to deliver information to where it hits home for them is different. And so that problem solving aspect, it takes so much out of me. I'm always exhausted, but the days at least fly by. I never feel like I'm twiddling my thumbs, and it just activates me in a way that I wanted to be activated.
So kind of piggybacking off some of the comments you made there, we get a lot of questions about work-life balance. So on average, how many hours a week do you work? How many hours do you sleep at night? That's a big concern for soon-to-be physicians. And also, how many weeks of vacations are you able to take?
Yeah, it depends on, because I also do some research, and I also do writing. And so if I've decided to write a new editorial on disability advocacy and it's due in 2 weeks, that those numbers balloon in a not so great way, but that's a choice of my making. And so I would say on average, and for rehab doctors that are pediatric rehab doctors on average, you will find the range of work hours that we work to be fairly reasonable by medicine standards. Rarely under 40, but rarely a lot over 50, 55 kind of thing. And that 55 range is going to be more the times where people are also covering inpatient units that have a little bit more need now, versus things that you can push around and find the time to get what you want to get done. And for sleep, it's funny. I've always needed a lot of sleep. Even when I was in med school, I needed 9 hours, and if I don't get 9 hours, then I quickly start to accumulate a sleep debt. So I still stay pretty close to that. Every once in a while. Right now, lately, I sometimes have some 7-hour nights, and that's also just because I'm going to bed early and then waking up early with my own kids and spending some time with them before I head out to work, because of this work from home world we're in. And vacation weeks, I think a solid 4 every year, mixed in between the holidays and taking trips that are solid week trips. So I wish I could be European about that and take much more vacation. And I would say by my mid-career on, I plan to double that. But at least for right now, I'll survive on the American 3 to 4.
Yes. So do you feel you have enough time to spend with your family? Why and why not?
I do, but I self-select into not really letting that be an option not to.
Mhm.
I think there are certain things that I just say no to and have started saying no to at a very early stage, even in my training, to say, if I can't be the leader or president or whatever have you because of that, so be it. I've never been very much I try to work against the rat race in any way I can, and one of those reasons that is I have a family with 2 kids and my wife, and we definitely try to have fun for that, and going like for this weekend, going down to see my dad and 2.5 hour drive away, and haven't been able to spend much time with him, but we're all vaccinated now, so
Yes.
those are things that are important.
Yes, getting back to normal. All right. In your position now, knowing what you do, what would you say back to yourself when you started your medical career?
Yeah, it is. It's so hard to say what I would say back to myself, except for me, I think it gets back to knowing who I am more. The things that when I started my career, I did not process my attention problems. I thought I was a procrastinator, and I thought I was, um, uh, you know, just a crammer, but that wasn't it. It was that I could not pay attention. And a part of the reason I couldn't pay attention is that it takes extra effort for me to pay attention with my hearing impairment. And I was already not thinking about my hearing impairment. So there's so much of how I'm a learner that has been just complete. I redo my college and medical school so different now because I really did not get the most out of what I could because of some situations. I kind of made up for it in other ways, and I clearly like to be thoughtful, but the sheer volume of what I was trying to study was overwhelming at times. And so, and the other thing for me at least is, if I could have known it at the beginning, I have pretty strong opinions and some of them political, so I wouldn't want to get into them in this setting, but about what we do to our nation doctors and what we make trainees do and how it kind of changes the doctor-patient relationship, especially in residency. Sometimes you feel like you're an assembly line and you feel like you're having to treat patients as quickly as possible, get them to where they need to go. And by doing that, the patients lose a little bit of their personhood to you. And recovering from that is really hard. And seeing it happen is really hard. And so for me, I would say back to myself of think about that early and often and try to think of ways to work against that because at least in my mind, there's this thing that you might have heard of called burnout. And for me, burnout is not the major problem with medicine. Burnout, in my mind, is what you would call victim shaming. Burnout is saying that it's on the doctors to find a way to be more resilient. And that's not the problem. The problem is the system is very capitalistic. And so what's happening is more along the lines of a theory called moral injury, which is the reason we all got into this to help patients and do good for the world is diametrically opposed to having to send another homeless person back out on the street after an ER visit where they got their primary care because they can't afford primary care. So that's the kind of stuff that I had not spent enough time thinking about before choosing medicine. And I would try to do some more because I think all of us need to think about what it is in our society that's doing that.
So what information or advice do you wish you had known prior to beginning medical school? You touched a little bit on that in your last response, but what else do you wish, man, I wish I had known that before starting this journey?
Yeah, I think some of it is all the different options that you have in residencies, knowing that it never occurred to me that every medical school doesn't have the same types of departments and that some schools are stronger in different ophthalmological specialties and different backgrounds of how the region answers their medical needs. And then, I think the knowing that how to get the most out of each step, you look back at it and, the book years, the clinical years, being a early year resident, late year resident, and a fellow, there's just so many different ways of thinking about what do I get the most out of this time and this time. And now when I'm trying to be a mentor, I really enjoy helping people kind of classify, okay, you're this is the time that you have now for this, and don't be too worried about trying to get skills that is going to be better suited for another part of your training. Mm-hmm. So I think that would be something that I would love to have known and trying to help maximize each phase.
Where do you see pediatric PM&R in 5 years?
Yeah, I am hoping that our field doubles, and that there's less than 300 of us in the U.S. And so that is partly because, again, the programs that are really strong in what we do continue to be strong, but the programs that are really weak in what we do continue to be weak. And to help us grow, it will require, again, us being vocal about what we can do, being in parts of the country where we might not otherwise be recognized, and help to grow that. And then at the time, to be a ped rehab doctor, you have to either know you want to be a ped rehab doctor out of med school and do a ped and a rehab combined program, which are only, I think, 2 of those, or decide you want to do peds after completing the 4-year adult program. And either track is at least 5, if not 6 years. And that leaves a lot of people who would have loved to do rehab, but they chose pediatrics first. And to get into rehab after choosing pediatrics first, you have to then go back to do a full rehab residency. It ends up being more years. And we're really in the midst of trying to find a way to open that up to pediatric residents who might then still want to be rehab doctors. Mm-hmm. And I think that would help us grow tremendously, because right now we don't have a track for them.
What advice do you have for disabled pre-meds, med students, residents, fellows?
Yeah, my main advice that I have found myself starting to give more and more is that if you want it, medicine is for you. Meaning that this feeling of, well, I can't, or I don't know how it would work, and I don't want to be a thorn in the side. If you understand that that feeling applies to disabled people and almost any endeavor in society that they're trying to be a part of. And yes, it might take some pioneering. Yes, it might take some frustrating meetings and times where you feel like you're really against the wall. And yet, by the same token, every step you take is treading that trail to be a little bit easier for the next person who tries to take it. And so I have just been finding more. There's a lot of us that are starting to really see a movement that one of the great things that will help medicine is that if we have more disabled representation in medicine. And not that I think that's the only thing we need to do, but I wouldn't want people to make assumptions about what parts of medicine are or are not accessible for them.
You touched on this a little bit earlier, but how is disability part of the larger diversity spectrum?
So I think it's really fascinating that when you start to realize the difference between disability and illness or disease or syndromes, that the fact that disability can't be cured, or that you can't snap a finger and erase it from the human existence is in some ways a good thing, because the disabled experience of life is not a net negative experience. And what I mean by that is, again, it's a privilege to grow old and to have a little bit more trouble walking than you did when you were in your 20s. It's a privilege to be a parent and to get times where you realize that your kids, for women, are part of the reason they might have other problems with postpartum depression or issues that they have to now kind of figure out, but yet they now have this part of their life that they wouldn't trade for anything. And really important part of an experience with, for example, hearing impairment is that I have friends and I think about how my ability to process a situation in some ways, because I can tune things out, helps me see the world in a different way. So you might have heard a term called neurodivergence. So that really sometimes applies a lot to people who have autism spectrum, and some of our most amazing people who have done mathematics or who have done other fields have been neurodivergent. And you think of mental health, and yes, it's important to get good care for mental health, but some of the most creative people in the world have been so creative and also have mental health, what would be considered other not typical mental health situations. So when you can separate the fact that, yes, that disability can come with parts of experience that might not be statistically normal, and yet might also not be what we call a net negative or a bad difference, but a mere difference, it becomes more like a part of diversity than it does to be an ostracized, stigmatized part of the human condition.
So our last question this evening. So in general, what advice for students do you have that might be pursuing a career as a physician?
Well, my advice for students in general is to remember to follow your passions and the ways that those passions make you well-rounded, or even the old term of Renaissance man or woman or person. And because those experiences that you will sometimes feel like you're nothing but a biochemical major who's having to take nothing but science courses, but the parts of your life that are not in chemistry lab are sometimes the ones that you'll use to connect with your patients and think about what your patients want to hear about and how they want to think about their lives. And that, in my mind, is one of the most important things as a physician, is to remember what makes you passionate and find a way to put that into your practice.
Really good and helpful information. Is there anything else that maybe we didn't touch on that you would like to share with those watching or that may watch after?
No, I am just really happy to have seen everyone today, and some great questions. I wanted to put in a plug of remember to share your pronouns. This is Pride Month, and being LGBT inclusive, I think it's very important. If you can, always try to find ways to help your presentations be accessible. I think that we have a caption that will be added on to this when it's posted, I believe. And this is the time to try to think about how everyone can participate in the things that we're doing.
Well, thank you so much again, Dr. Lunsford. This was a wonderful conversation. We greatly appreciate you taking the time out this evening to answer our questions. And thank you to those that watched. Thank you for asking questions and attending the webinar. If you did join us late, this will be available for viewing on YouTube. And again, we would just like to extend our gratitude to Dr. Lunsford for taking the time out to answer your questions this evening. And lastly, we would like to remind you that we have many donor-supported tools and resources available on our website. studentdoctor.net to help you with your journey to become a healthcare professional, and we invite you to check them out. Our next webinar is scheduled for next Wednesday evening, June 9th at 8 p.m. Eastern Time, and this one will be in partnership with accepted.com, where they will be sharing tips and strategies for answering your secondaries. So very timely. We're excited to hear their expertise and share with you guys, and we will actually share the link to that webinar for you to sign up in the chat this evening. Again, thank you so much for joining us, and we hope you have a great evening.
Take care.